Okay, let's do interpretation of medical tests. This is kind of changing gears a little bit. It's probably take about 10 minutes to do, and then hopefully another 10 minutes I'll just finish it up. All right? All right. Questions about what I talked about so far? No? It's a lot of information, right? But it's mostly terms. We don't really go into deep diseases. That's why I said the first 25% of the course is like this. All right, so how do we interpret medical tests? Okay? Healthy and sick. This is referring to whether or not the patient actually has a disease. Okay? As opposed to normal and abnormal. That's telling you that this describes observations and measurements. Lab tests are abnormal. Lab tests are not sick. Does that make sense? Right? But with that said, can a person have a normal test and be sick? Yeah, absolutely. As much as can a person have an abnormal test and not be sick? Yeah. All right? So there's a difference between that. Okay? And you can see over here, this is showing you a health, so the population, let's say, people that are healthy and people that are sick. This is people with a normal test, and this is people with an abnormal test. So usually, people that are healthy have a normal test. Usually, people that are sick have an abnormal test. But there's going to be a small section that will be healthy with abnormal tests, and also people that are sick with normal tests. So understand that, okay? Now, we have positive results and negative results, all right? Who here has statistics? Did they go over false positives and false negatives and positive predictive values, stuff you're actually going to use? A handful of people. Okay, so let me go over this, all right? A true positive test is a test that is positive and the PT is patient, and the patient actually has a disease. All right? Positive test. You get a mammogram. That's the test, and it shows you have breast cancer. Well, not breast cancer, but you see some kind of lesion there. That's a positive test. A false positive is a test that's positive and the patient doesn't have the disease. I do the mammogram. It shows that there's we call it a popcorn lesion, which is a calcification over there. But we do further tests later on, and she doesn't have it. That was just, I don't know, some kind of artifact or something else there. It doesn't have the disease. It's called a false positive. We have a true negative. If the test is negative, the patient actually doesn't have the disease. That's what we want, right? And we have a false negative where the test is negative, but the patient actually has a disease. Not a good thing. I do a mammogram and it shows you have nothing. Meanwhile, you have breast cancer there. Maybe it wasn't getting the right angle. Maybe it was too small to pick up with a mammogram, right? So this is putting it all together, what I just explained. You can do that, look at it afterwards. All right. So keep this in mind too. Now, I wish I actually could find an actual source of this, but after I talked to a lot of doctors, and in my experiences, and talking to nurses and radiologists, they're all, I'm getting it from credible people. I just haven't seen written anywhere. But keep this in mind, because I'm hearing it quite often. 20% of radiological tests are false. 20%. Meaning, 1 in 5 mammograms show a mass, and there really is no mass there. And 1 in 5 normal mammograms, there is an actual mass. Scary. So what I'm saying is that if you have a mammogram done, and it shows normal, there's a 20% chance you really actually have cancer. That's a big percentage. So we got to go further. Okay? It's kind of like if I do a pap smear on someone, okay, and I put a speculum in, I look at the cervix, I don't see anything, I'm still going to do the pap smear, send it off, come back in 2 weeks, it comes back normal, it's fine. Okay? Or it comes back and it says that there's a possibility of dysplasia there. I have to have the patient come back in. I take a biopsy now, something more specific, and we'll get into that in a moment. But what I'm trying to say is if I put a speculum in there and I see something there, I don't want to do a pap smear. There's no reason for that. I see something there. I'm just going to take the biopsy. Does that make sense? All right? So what I'm saying is the mammograms are helpful, but you have to also go further. You have to talk to the patient, and because if it doesn't look like that. Another good example is I had knee surgery. So prior to knee surgery, they couldn't see what was going on, but before they did the MRI, it sounded like I tore my meniscus. Sounded like that, if it sounded like that, if it represented that, but let's get an MRI. They do an MRI and it shows it's completely normal. But my symptoms and signs still say that I have a torn meniscus. That's what the doctor says. Well, I'm a doctor, so doctors are hard patients. But that's what we were thinking. So what we decided to do, or what he decided to do, we'll say, is that he put a scope in. Put a scope in, and lo and behold, torn meniscus. I was in the 20%. Things could go wrong. So you've got to also take a history and physical to see what's going on, because things could go wrong. Breast, the breast, if the woman says that she feels a lump and you can't pick anything up there, we have to look at it closely if there's anything else going on. Okay? All right, sensitivity and specificity. Okay? Sensitivity is the ability of a test to be positive when the disease is actually present. Mathematically, it's the true positives divided by the true positives plus the false negatives. Right? The false negative is really a positive. So we're getting the true positives divided by all the people with disease. See how you get that? Right? And sensitivity rules out the disease. Meaning that if we see a patient who has this test done and it comes back positive, or it comes back negative, we know that that patient does not have that disease. Or it rules, I'll show you the next part. Specificity is the ability of a test to be negative when the disease is absent. Right? So mathematically, it's the true negatives divided by the true negatives plus the false positives, because the false positive is really a negative, right? These is the people that are truly negative over all the people that don't have the disease. Does that make sense? See the percentage? And I'm going to show you this over here. So specificity rules in the disease. It's going to say that this person has it. Now look. The other mnemonic that I have over here, and that's where I have this, so here, the false positive, so PP, right? So that's where I had that little mnemonic. But you could also do spin. I'm sorry. No, I did that right. You could have snout, and you could have spin, right? So sensitivity rules out the disease, specificity rules in the disease. Does that help you? Okay? So let's show you this example of how we put this together. Okay? So let's talk about a disease, and we're going to deal with a population of, let's say, 100,000 people. And this specific disease, whatever it is, there's a prevalence of people with 1%. So 1% of this population has the disease, which means that there's 1,000 people that have the disease out of 100,000. That's what that means. So how do you put this all together? All right. Positive tests with people that have the disease, that's a true positive. People with a negative test that don't have the disease, that's our true negatives. That makes sense, right? You could have a positive test with no disease. That's our false positives. And then a negative test where you actually have the disease, that's our false negatives. You see where I'm getting all this? Right? All right? So sensitivity, so let's plug in numbers. Here's the math, here's the formulas. So the formulas over here, when you put in these numbers, if you have 980 people with a positive test that actually have the disease, and then you have a negative test that actually have the disease. You put them all together, you got 1,000, right? Because I said 1,000 people with the disease. So what you're going to do is that sensitivity equals true positives divided by true positives plus the false negatives. Right? Make sense? Think about true positives over everyone with the disease. So this means if we plug in numbers, true positive is 980 over 980 plus 20. Right? Right. So then you're going to have 980 over 1,000. Cross this off here. And the sensitivity is 98%. Right? Which is pretty good. That test has a very good sensitivity. The 2% we got to worry about. But 98%, it's going to rule out the disease. If it comes back negative, you're not going to have it, right? And you can do the same thing with the other one. So a test with a highly sensitive, you test first with a highly sensitive test. You do that first. Also, let me just also tell you, most sensitivity tests, they're cheaper than specificity tests. So insurance companies want you to do that anyway. Okay? So, and I'll give you an example in a moment with what's going on here. So once you do the sensitivity test first, you then test all the people that were positive here, and you go further to the next test, which is the specific test. Okay? And like I said, specific tests tend to be more expensive than sensitive tests. So it's another good reason why you would do that. So let's put this stuff together. Okay? Let's do the pap smear again, because that's my bread and butter anyway. Okay? I can keep it related. So you have the pap test done. The pap test is a sensitive test. It's a screening test. Okay? And what's going to happen is we are going to do the pap smear to test for cervical cancer. Okay? Or signs of a prodromal period or something that can lead, maybe a precancer state. So we're going to do the pap smear, and we have positive people. So there's going to be a positive test with that. All right? And let's say 4 people had a positive test. We're going to find that 1 is really a false positive. But we have people with a positive test. Then we have negative. And most people have negative over here. There might be someone that will have a false negative, though. Okay? The positive test, if it comes back as positive, we now have to go for a specific test. Which means we got to take a biopsy. Does that make sense? When we take a biopsy, Now we can see it more specifically. It's going to rule in the disease. I take a biopsy, we look at it. That's much better than taking some scrapings off the cervix. But it's a screening test, the pap smear. We got an actual piece of the tissue that we looked under the microscope. Much more specific. Okay? And it's going to rule in. It will find those 3 people, because we can see it better, and there's one other person who will do this kind of thing, right? Because that was positive, but this was okay. And you know what I'm talking about. You probably had some tests before. You did this test first, but then the next test was okay. Right? That's what happens over here. In this case over here, if it was a negative pap smear test, okay, they will re-smear in the next year. Okay? It's this one patient that will be diagnosed with cancer. Unfortunately, and that's what I'm trying to emphasize to you. We do the best test we can, but there's going to be a small percentage of people that are going to squeak on by. Not anyone's fault on that. It's just no test is 100%. So that's why we need to see, or our patients need to be aware of signs and symptoms that maybe they can see. Luckily, cervical cancer is a very slow-growing cancer. To go from, let's say, stage 1 to stage 2 cancer, that takes about a year or 2 for that to actually happen. Okay? We all know that from TV commercials that cervical cancer is due to HPV, or human papillomavirus. It's an infection. So we'll learn about, when we get into neoplasia, certain infections cause cancer. Okay? So what's going to happen here is that if a person's got HIV, then this HPV, remember what HIV does, it's going to lower your immune system. Like I said, cervical cancer takes a long time to actually spread to advanced cancer. But if you have HIV, it'll happen much faster because your immune system can't fight off the HPV. So, I'll give you this example. I see a patient, she has a normal pap smear now. Or even if she has, let's say, stage 1 cancer, but she never came back for follow-up. She comes back to me next year, and she's got stage 4 cancer. That's way too fast. Usually it's like 4 or 5 years to get to stage 4. So yes, she has to worry about cervical cancer, but there's another problem that I think she has to worry about also, which is what? HIV. You see what I'm saying? She could have been on corticosteroids. That also lowers your immune system. So there could be other reasons. That's why you got to take a history. But that's where you're putting things together. It's not about memorization. It's about being able to understand why they're getting these signs and symptoms. Okay? Okay, so I want to talk about predictive value. Okay? This also deals with sensitivity and specificity, but on a different wavelength. But it does interact with that. But I want you to understand this is very important for you guys to understand. A predictive value is it's a value after you calculate it, which I won't ask you about the calculation, but it predicts who has and who does not have the disease. Okay? The best test has a very high predictive value. We're going to talk about positive predictive values and negative predictive values. Okay? So that's what we're going to talk about. Is a high one is what we want. A high positive predictive value and a high negative predictive value. Okay? So a highly sensitive tests tend to have high false positives but low false negatives. So in other words, a negative result in a highly sensitive test has a high predictive value. I'll show you what I mean by that. Okay? So highly specific tests tend to have high false negatives but low false positives. So a positive result in a highly specific test has a high a high predictive value. Okay? So let me explain to you with this. We have a positive predictive value, and that states that the probability that the patient has a positive screening test, or let's even use a positive risk factor. If you have the positive screening test, or a test that's positive, or in another case, a risk factor that's positive, then that person has a disease. Like, it would make sense. It would highly correlate that if you have this test that's positive, then you have the disease. If you have this risk factor, then you have the disease. Okay? That's what we want. So if you have a high positive predictive value, then there's a strong probability that they have the disease. But if you have a low positive predictive value, the probability is very weak. Okay? So this is my example. Let's use a risk factor. Okay? A high positive predictive value is people who smoke, so people who do smoke, will develop lung cancer. Now, that's what we call a positive predictive value, meaning that it would be good, not good, but it would be a good prediction that if this person smokes, then 100% of the smokers are going to get lung cancer. That's what we want. We want that to be the highest thing. If you have this risk factor, or you have this screening test that's positive, then you will have this disease, because there's a strong correlation. Now, a low positive predictive value is people who do smoke, but they don't get the cancer. It doesn't correlate well. We want to say, if you smoke, you're going to get cancer. But if you do smoke, then you're not going to get cancer. So then that doesn't correlate. Okay? So that's what we want to say, that between a high and a low positive predictive value. Now questions? Okay, so let's talk about negative predictive value. And it's kind of the opposite of this, but I'll use the same example. So a negative predictive value is the probability that patients with a negative screening test, or someone who doesn't have that risk factor, will not have the disease or won't get the disease. Okay? So again, similar to positive predictive value, a high negative predictive value, the probability is strong. A low negative predictive value, the correlation or the probability is very weak. Let's go back to the lung cancer and the smoking. Okay? A high negative predictive value would be people who don't smoke don't get the disease. So people who don't smoke won't get lung cancer. You want 100% of people who don't smoke will be 100% of people who don't get lung cancer. That's ideal. That's what you want. Not every test is like that. Not every risk factor is like that. I can't even think of one that's like that. But you want to have something that's pretty close to that. As opposed to a low negative predictive value is people who do not smoke will develop the lung cancer. And we know that happens. God, he got lung cancer, and he never smoked at all. Right? So that is what we call a low negative predictive value. So let's just put this in chart form, at least the example, so you can see what's going on here. Okay? So what we're saying here is that here's a smoker, and are they a smoker, and do they get lung cancer? So a high positive predictive value states that he is a smoker, he gets lung cancer. Okay? A low predictive value says that he's a smoker, but he doesn't get cancer. There's no correlation. Okay? A high negative predictive value says that he's not a smoker and he shouldn't get cancer. But a low negative predictive value is stating that he doesn't smoke, but he does get lung cancer. It doesn't correlate. See that? So you want something with a high predictive value, or a high positive predictive value, yet a high negative predictive value. People who smoke will get the lung cancer. People who don't smoke won't get the lung cancer. That's the ideal thing, but we all know that in the medical realm, in the real world, it's not going to be 100% like that. But we want to get a test. We want to get risk factors to show that there's a strong correlation between the two. Okay? So that's what positive predictive value and negative predictive values are all about. Okay? Questions on that? That shouldn't be too hard, especially if you use my example. No?